Have you ever heard the phrase collapsed lung and wondered what that really means? Today we're breaking down pneumothorax. What it is, how it happens, the red flag symptoms you must never ignore, and what doctors do in an emergency. Whether you're a patient, a family member, or just curious, by the end of this video, you'll know the facts that can save a life. Don't miss out. Tap the subscribe button now and save this video so you can come back to it anytime. Pneumothorax is the medical name for air that has escaped into the thin space between the lung and the chest wall, the pleural space. When air collects there, it pushes on the outside of the lung and causes the lung to collapse partially or completely. In simple terms, air where it shouldn't be, making it harder for the lung to expand and for the body to get oxygen. This can be a mild, self-limited problem in some people, or a life-threatening emergency in others. Clinicians divide pneumothorax into several practical categories. Primary spontaneous pneumothorax, PSP, occurs without trauma or known lung disease, often in otherwise healthy young people, typically tall, thin men. It's commonly caused by rupture of a small subpleural air pocket, BLEB. Secondary spontaneous pneumothorax, SSP, happens in people who already have lung disease such as COPD, cystic fibrosis, or severe asthma. Because their lungs are already fragile, SSP is often more serious. Traumatic pneumothorax, from a direct injury to the chest, a fracture of a rib, a stab or gunshot wound, or even certain medical procedures like lung biopsy or central line placement. Tension pneumothorax, a special emergency form where air enters the pleural space and cannot escape, causing rising pressure that compresses the lung and shifts the mediastinum, heart, and great vessels. This can rapidly lead to low blood pressure, shock, and death unless decompressed immediately. Tension pneumothorax is treated as a clinical emergency. The most common mechanism is rupture of a weak spot on the lung surface, a BLAB or a bulla. When that micro tear opens, air from inside the lung escapes into the pleural space. In traumatic cases, the chest wall is breached and air leaks directly. Certain medical procedures or mechanical ventilation can also introduce air. In tension pneumothorax, the leak acts like a one-way valve. Air enters on inspiration but cannot get out, so pressure accumulates. Risk factors for spontaneous pneumothorax include being tall and thin, smoking, and underlying lung disease. Recent research also highlights age, low body mass index, and prior contralateral pneumothorax as predictors of recurrence after a first event. Common symptoms depend on the size of the pneumothorax and the patient's baseline lung function. Sudden sharp one-sided chest pain, often pleuritic, worse with breathing. Shortness of breath, ranging from mild to severe. Rapid breathing or heart rate, lightheadedness, or fainting in severe cases. For tension pneumothorax, severe breathlessness, low blood pressure, neck vein distension, and tracheal deviation. Clinical signs of cardiovascular compromise. Important point: people with large pneumothorax can rapidly deteriorate. If someone becomes very breathless, pale, or dizzy, call emergency services immediately. Don't wait for imaging. Physical exam. Doctors may hear decreased or absent breath sounds on the affected side, reduced chest movement, and sometimes hyperresonance on percussion. But exam alone can miss small pneumothoraces. Chest X-ray, the primary initial test. A chest X-ray shows a visible line where the lung edge is separated from the chest wall with absence of lung markings beyond that line. Point of care ultrasound, POCUS, increasingly used in emergency settings. Lung ultrasound can detect pneumothorax faster than X-ray in some cases and is portable. CT scan, the most sensitive test, used when X-ray is unclear, when there's doubt about severity, or to evaluate underlying lung disease. CT is often used in planning surgery or when recurrent events occur. Management depends on three major factors: clinical stability of the patient, vital signs, breathing, size of the pneumothorax, small versus large, on imaging, whether it's primary, secondary, traumatic, or tension. General approaches. Observation and oxygen. Small pneumothoraces in stable patients, especially primary spontaneous, can often be observed with supplemental oxygen and repeat imaging. Oxygen speeds reabsorption of pleural air. This conservative strategy avoids invasive procedures for many patients. Needle aspiration. For larger symptomatic pneumothorax, simple needle aspiration, pulling air out with a syringe, may succeed, especially for primary spontaneous pneumothorax. This can be done at the bedside. Chest tube, tube thoracostomy. For significant or persistent pneumothoraces, secondary pneumothorax or after failed aspiration, a chest tube is placed to continuously drain air and allow the lung to re-expand. It's often connected to an underwater seal or suction. Ambulatory management. Newer pathways and guidelines support ambulatory care, portable one-way valve systems, in selected patients who can be safely followed at home. This reduces hospital stays when suitable follow-up is available. Surgery. Pleurodesis, VATS. For recurrent pneumothorax, persistent air leak, or in people whose work or lifestyle makes recurrence dangerous, pilots, divers. Surgical options like video-assisted thoracoscopic surgery, VATS, and pleurodesis, creating intentional adhesion between lung and chest wall, reduce recurrence risk. BTS and other guidelines outline when to consider elective pleurodesis. Tension pneumothorax is a clinical emergency, if suspected, for example after trauma, or in a suddenly deteriorating patient with severe breathlessness and hypertension. Do not wait for an X-ray. Immediate decompression is required. Needle decompression, large bore, long needle, into the pleural space is performed to release trapped air. Traditionally taught site, second intercostal space mid-clavicular line. Recent studies and pre-hospital guidance also support mid-axillary fifth intercostal space for some providers and recommend appropriate needle length. Meta-analyses suggest 7 cm may be suitable in many adults. After needle decompression, a chest tube must be placed for definitive management. If you are not a trained clinician, call emergency services immediately. In the pre-hospital setting, emergency medical clinicians are trained to perform needle decompression when indicated. Patients with underlying lung disease, SSP. Even a small pneumothorax can be dangerous because baseline lung function is poor. These patients more often need early tube placement and hospital admission. Mechanical ventilation. Positive pressure ventilation can make pneumothorax worse. Risk of tension physiology. ICU teams monitor closely and often intervene earlier. Pregnancy. Management must be individualized, balancing maternal respiratory status and fetal safety. Chest tubes can be used when necessary. Young patients with PSP. Many do well with conservative treatment or aspiration. However, recurrence risk is substantial and needs counseling. Recurrence after a first spontaneous pneumothorax is common. Reported recurrence rates vary, but can be significant. Risk factors for recurrence include younger age, low BMI, smoking, and certain anatomic features. For people at high risk of recurrence, or for those whose job makes recurrence dangerous, preventive surgery, VATS with pleurodesis, is often recommended. Guidelines from thoracic societies outline the thresholds for offering surgery. Quitting smoking substantially reduces recurrence risk. After successful treatment, patients usually get follow-up chest X-rays to confirm re-expansion. Many patients recover fully and return to normal life, but advice on activities, air travel, scuba diving, high-altitude travel must be given. Avoid air travel or scuba diving for a recommended time after pneumothorax and get clearance from a chest specialist. These restrictions are important because changes in ambient pressure can re-expand trapped intrathoracic spaces or precipitate recurrence. Stop smoking. This is the single most important modifiable risk factor. Smoking increases the chance of spontaneous pneumothorax and recurrence. Get prompt care for sudden chest pain or breathlessness. Don't dismiss symptoms as just indigestion if breathing is affected. If you've had one pneumothorax, follow up with a chest specialist. Discuss lifestyle limits, recurrence prevention, and suitability for procedures like VATS if recurrence occurs. For people with chronic lung disease, regular care, inhaler adherence, and managing exacerbations reduces complications. Be cautious with certain activities. Consult a doctor before flying or diving after a pneumothorax. Recent clinical work has focused on less invasive and ambulatory management for selected patients, improving comfort and reducing hospital stays. Advances in imaging and bedside ultrasound have speeded diagnosis. Research is also addressing the best needle length and site for emergency decompression to reduce failed attempts and complications. Thoracic societies continue to refine guidelines to select patients for conservative versus invasive management. Mr. Park, a 52-year-old office worker, woke with sudden sharp chest pain and breathlessness. He thought it was indigestion, but his wife insisted on the ER. A chest X-ray showed a large pneumothorax, and a chest tube was placed. He recovered fully and later quit smoking. Early action made all the difference. Pneumothorax, meager air in the pleural space causing lung collapse. Watch for sudden one-sided chest pain and shortness of breath. Tension pneumothorax is an emergency. Immediate decompression saves lives. Not every pneumothorax needs surgery. Many are managed conservatively, but close follow-up is key. Quit smoking and follow your specialist's advice to reduce recurrence. If this video helped you, please like and subscribe. Share with family and friends who should know these signs. If you or someone you know has had a pneumothorax and want to share your story, leave it in the comments. It could help someone else get care faster.